Dr. Anil Patel, welcome to Auckland.
Thank you very much for having us. It's been very nice.
You've been here for a few days, you've come over from London. How have you found the ANZCA ASM so far?
Well, it's very well organised, very professional. I was just hearing that there's about over 1,700 people here. It's about a third of the whole anaesthetic community, and maybe just it is absolutely.
Now, you've just finished your presentation on the Thrive study, and it's been described as a game changer. In what way has it been a game changer?
Well, I'm not sure it's a game changer, but it's a very interesting piece of work, I think. It allows us to effectively buy some time, and allows us to think while we're doing sometimes quite difficult things around laryngoscopy and airway management. And I think that's probably the key take-home message, that we've sort of stumbled across a technique that allows us to maintain oxygen saturations for quite considerable periods of time, which allows us to sort of step back, not be rushed, not be stressed, because once we start to desaturate, we do get stressed. And it just allows our brains to work in a more controlled, coordinated way. And I think although the study is obviously about preventing desaturation and clearing CO2, and a tool to be able to do that, it's actually about human factors and the ability to be able to think and not get stressed. It's actually about the brain more than anything else.
You talked about we stumbled across this. Can you elaborate on that?
I'm sorry, I didn't catch that.
You said you stumbled across this process. How did that come about?
Yeah, so in our hospital, we're often getting asked to have a look at pieces of equipment around airway management. And a few years ago, Fisher and Patel, who make the Optiflow system, suggested that we might want to have a look at the nasal Optiflow, nasal high flow, for patients who were waking up, so during the extubation process. There's lots of evidence in the literature, about 1 million uses of that for intensive care patients, either going off to sleep or once the tubes come out, so waking up. And we thought it was a good idea, and we thought, well, let's have a look at it. I have to be honest, most anaesthetists that I spoke to who are not involved in intensive care work, none of us have ever heard of it, actually. So I picked it up as a tool that has been that intensivists have been using for a decade or so. But 3 plus years ago, when we were introduced to it, I'd never heard of it. So we stumbled across it. We then we used it for waking patients up, and we thought, yes, there's an obvious added benefit from waking patients up. And then we thought, well, maybe we can get some benefits from going off to sleep as well. So we started using it to supplement oxygenation during the pre-oxygenation period, and again, stumbling across this, we found that it seemed to prolong the apnea time quite considerably. So the very first time we noticed that was a trainee who was struggling with a difficult airway to intubate, and ordinarily during that process the trainee would have stopped the laryngoscopy, we would have had to put a face mask over the patient, we would have had to got the saturations back up again by bag mask ventilating. And what we found was that actually the saturations didn't seem to drop. And actually it didn't seem to drop for quite a long time. And it just went from there, really. We started using it more and more, and then we got to a stage where we were undertaking surgical procedures with it, microlaryngeal type procedures, and we've been doing that for a number of years now. So that's how we now undertake vocal cord surgery.
Tell us about some of the learning objectives, the principles behind the results of the study.
So some of this is we've just, again, really only thought about, found out in the last year or so. So we were using it and we knew it worked, and we could see that our end-tidal CO2s were lower, and we could see that our oxygen saturations maintained very high for significant periods of time. But actually we didn't know why. And it's only really in the last year or so that there's been a lot of work gone into trying to model what's actually going on. And we've got not a complete understanding, but we've certainly got a better understanding than we had a year or two ago.
And how about the applications going forward? How do you see these evolving?
So that's very exciting actually. So some of them are extensions of intensive care use. So I think endoscopy type procedures is potentially a really big area. So whether you do bronchoscopies or GI endoscopies, first we're not entirely sure worldwide whether anaesthetists are involved with them. Generally not. It's usually the endoscopist, the bronchoscopist or the GI endoscopist who often sedates these patients. I'm not entirely clear, and I'm not aware of significant data that tells us how many problems these millions of patients that are having this procedure have over periods of time. We do know, we get anecdotal reports of problems patients running into problems, particularly during, for example, bronchoscopies undertaken in patients who have advanced airway tumours, EBUS type procedures. The bronchoscopies in patients with significant airway pathology is an advanced, not risk-free procedure. Now, applying nasal high flow for that group of patients in our experience, and there's a number of groups now that have started to do it, and they're starting to produce the literature. It suggests that there's a lot more stability in terms of oxygen saturations. The endoscopist is very happy that we're not having to intervene and the patients aren't desaturating. So there may be some significant advantages there in that group. Then there's anesthesia groups, if I can use that term, so rapid sequence intubation patients, and there's some studies going on in that which seem to show that it extends the apnea time, and it again gives us time to do things in a more controlled manner. We're not rushed. I think it's useful for potentially for obstetric patients, and there's some studies that are going on in that. And then, of course, what we've been using it for, sort of difficult airway patients, where you're either expecting a difficult airway or an unknown difficult airway, or you think there's going to be some problem with the airway.
Lots of exciting times ahead for you and lots of discoveries, but through Thrive you've also learnt what it doesn't do.
Yeah, absolutely. And actually so 2 years ago we were very excited that the technique seems to work. And I think, certainly in our minds, the conversation has moved now from not trying to establish whether the technique works. We're pretty sure it does work. Actually, what's more interesting is to try and define the limits of it and where it doesn't work as well, and where it may not be suitable. So the sort of subgroups where we think that the apnea time will not be as long are, for example, morbidly obese patients, particularly super morbidly obese patients. So whereas a slim patient, we can use the technique and the patient can remain apneic for half an hour, 40 minutes, an hour. In an obese patient, that number is much lower. It's 7, 8, 9, 10 minutes. Now, that's still probably many factors more than with standard pre-oxygenation, but it's not as good as half an hour or an hour. So obese patients are definitely a limit. Total airway obstruction is another limit from whatever cause. So attention to detail around keeping the upper airway open is very important, and we've got to ensure that. So we need to do good jaw thrust type manoeuvres to keep the upper airway open. And then the other thing that we're realising as people start using is that sometimes people are confusing that this is a technique that can deal with a patient who has already desaturated. So this is a technique that allows us to extend the apnea time and prevent desaturation for quite considerable time. But if desaturation does happen, and sometimes it will happen, this is not a rescue tool for that desaturation. So it is not a substitute for a patient who has desaturated for whatever reason. That's not the time to put Thrive on, because it won't work. It's a holding rescue manoeuvre. And the other thing that's probably critical for all airway management is that you can't. I don't think one should approach a complex airway or a potentially difficult airway with the thought that I'll put this on and therefore I don't have to think and everything will be okay. Actually, you still have to think. You still have to plan for that difficult airway. You still have to have a plan A and a plan B and a plan C. What this will hopefully do is allow us to extend the time period and reduce some of the stresses around desaturation, and therefore you've just got a time to think and probably time to behave in a slightly better way.
Nice way to finish, because you started on time was the great discovery, and our time is over as well. Thank you so much for talking to us, and I know so many people are so